for lab services at the Clinton Health Access Initiative based out of Washington. He has tons of experience, more than 20 years of experience in international health, research, diagnostic medicine, ranging from public health intervention implementation to strengthening lab capacity in low and middle income countries, to infectious disease epidemiology, and most recently, COVID-19 diagnostics. He's worked in Africa, Asia, Eastern Europe, Central and North America. I was looking through this and I wondered, Trevor, is there any place that you haven't worked?
Australia.
Over to you, Trevor. Australia! See, that's the only place you haven't worked. That's amazing. Thank you, Trevor. Over to you.
Great, thanks so much, Nikki. And I will take the liberty of going off video in a minute. And with apologies, we all work from home, and I need nowadays I need to avoid any sort of audio interruptions. So I'm going to move my location in a minute. So I'd like to start by just giving a bit of preamble to the presentation. I think all of us are familiar with the fact that over the last year, the world has been in many ways turned upside down by this by the COVID-19 pandemic, and it has placed enormous pressures on many different aspects of society and business, the way people live, and of course, healthcare in particular has had to change and adapt dramatically. In fact, many aspects of healthcare delivery, innovation, development, and delivery have been driven by one single objective over the past year. So my presentation will focus on what this change has looked like since around about March 2020. From a diagnostic perspective, I'll talk about the technology changes, but I'm going to also focus a lot on the delivery of healthcare services and diagnostic services in particular in low and middle income countries, and what sort of innovations had to be sort of adopted both at a global level or an international level to support epidemic responses in LMICs or low and middle income countries, and of course what sort of innovations and changes needed to be taken on at a country level. And then I'll try and bring that together sort of with a sort of looking forward perspective and consider what it means also for the diseases. So just to sort of frame our thinking and give us a sense of what has happened with COVID-19 test technologies over the past year. Right in the very beginning, what we call sort of phase 0, soon after the initial infection and as the disease was spreading from its original sort of point of outbreak, diagnosis was initially clinical, and then very rapidly through sequencing, some of the early tests were developed. And these tests were conducted in research and reference laboratories, as we know, and run on diagnostic technologies that were what I would call here sort of open PCR, open or manual PCR. These are these sort of in-house. There were in-house test kits, primers and test designs based almost like in a research basis. Those quickly evolved in the first quarter of last year into assays that were to some extent commercially available and were being distributed by the WHO to countries around the world to enable them to diagnose COVID-19 as it was spreading. And at the end, roughly about the end of the first quarter, the rapid development of those tests was an incredible feat to have those available so quickly and distributed so quickly through the intervention of the WHO to so many countries. But by the end of the first quarter, it was recognized that we were moving into a pandemic phase with this disease, and testing was really the only intervention that we had available. a new technology approach needed to be taken to deal with the scale of testing that was needed. Some of the traditional nucleic acid testing companies, such as Roche and Abbott, Cepheid, Hologic, which have automated testing systems, high volume as well as point of care automated testing systems, by that stage in April came out with sort of their assays for COVID-19, their nucleic acid testing assays. Again, a very rapid development of these assays, and they were deployed. And so that we sort of moved, I would say, into sort of phase, what we call phase one, which was the sort of early availability of those open PCR commercial assays that WHO supported, as well as the automated platforms and the expansion of testing. Now, that expansion of testing on the automated platforms was only possible because of the previous infrastructure that had been established in many countries, and established often in most cases because of earlier investments in HIV and TB testing, and this has this capacity was very valuable, and I'll explain that in a minute, because it allowed a very rapid implementation. It also had some inherent challenges that I'll explain as well from a supply perspective. Phase two sort of kicked off roughly 6 months later, in sort of roughly the end of September of 2020, with the introduction of rapid antigen tests, which was simple lateral flow assays, allowing greater decentralization of testing and a sort of much faster testing turnaround time. The graph on the left here describes I would say, the sort of dramatic increase in volumes of tests run. Almost 500 million tests run in the course across low and middle income countries over the course of sort of March to December last year, and that's faster growth in testing than I think that has been seen in any other disease. Not, I think it's definitely faster than it has been seen anywhere else. But in addition to just the absolute scale, the dramatic scale of testing, what has been quite unique has been the pace at which the market for COVID-19 tests has changed. There's been a rapid evolution of this market. Today we have well over 20 suppliers that have sort of well-validated, high-performing PCR test kits that the WHO has reviewed and lists on its emergency use list. That has been, and these tests have been assessed by studies that FIND and others have conducted. And these tests also have an average price below $12. In fact, now they're sort of rapidly dropping below $10. And that's a market evolution in terms of the number of available suppliers and the pricing dropping significantly from a starting point of roughly about $20 back in April. Actually maybe $20 to sort of $15 to $20. The pace at which the pricing has dropped has been very fast. There's sort of more than a halving of the price over the course of less than a year. In addition, swab suppliers have grown, high quality swab suppliers to match the number of tests that have been run with low cost swabs, so under $1.50. And what's important here is that I think that there continues to be even more innovation with the swabs and different swab types. Nasopharyngeal swabs have been the primary swab type used in the past, and now there are sort of nasal swabs and potentially even sort of tongue scrape swabs coming in future. And the pricing is dropping even further. Some of the current best pricing is roughly about 30 cents per swab. So that's, from a market dynamics and market sort of healthiness of the market perspective, there's been a rapid evolution that we sort of consider to be a very positive thing. In addition, I mentioned antigen tests coming in as sort of phase 2 of technology development. And currently, since September last year, have been 2 WHO approved antigen test suppliers. Their pricing started at $5. It's now between $3 to roughly $3.70. And around the corner in the next month or two, there will be another, the already are starting to be available, some even cheaper antigen tests, roughly $2. And we expect probably by the end of the year, rapid antigen tests are going to sort of cost roughly about $1, which is sort of roughly the price of an HIV rapid test, which is the other sort of most widely used high volume rapid test used worldwide. And then we also expect that within LMICs, low cost, high quality rapid antigen self tests will become available. Self tests are already available in a number of countries. They're a bit high cost, but we expect sort of cheaper, high quality versions to be available soon. So overall, very rapid evolution of this market because of the enormous demand and enormous pressure to get tests into use and deployed. Now, one feature of all this sort of change and the growth in demand and the need for tests has been a sort of very acute gap in supply. Now, for most low middle income countries, particularly those with sort of less buying power, it's been a real challenge over the past year to secure sufficient quantities of PCR tests. And this has placed a lot of pressure on governments. They've often been, really, this has been something which prime ministers and presidents and have had to sort of get involved in. It's basically trying to negotiate and secure quantities of PCR tests. That was really unfortunate, partly because of the global demand. Every single country was purchasing these tests, and there simply wasn't enough manufacturing capacity. And that's in sharp contrast to what this map here shows, which is that at the time of the start of the COVID-19 pandemic, there was significant diagnostic infrastructure, laboratory instruments capable of running tests across the world within LMICs. Over 15,000 instruments that were of the automated variety, capable of running over 20 million tests per week. And so that's an enormous diagnostic capacity, but unfortunately, really sort of undermined by a lack of supply. And that's been something which has been a real focus of sort of innovation to try and find new ways to get tests done using alternate platforms. And one of those platforms that I want to highlight here is what I referred to earlier as a sort of the open or manual PCR platforms. And some of you may or may not be sort of familiar with these. These are sort of the sort of the normal PCR machines that are available in many research labs, which because of the significant gaps in supply of the automated PCR tests that existed last year, many of these manual PCR machines were sort of pressed into use, sort of taken out of their research or other sort of function, and almost like in many countries nationalized for COVID testing. And what was really surprising to many was the number of these instruments and the sort of capacity that they had. So, over 4,500 instruments in LMICs worldwide, capable of over 10 million tests per week, and that's an enormous capacity. Now, what was different about this, and this is in many ways a sort of innovation that has been made sort of possible through the COVID-19 sort of pressure, has these machines have been brought into much more widespread use, put into public testing, and today continue to be used. and have now been recognized as an extra resource for further diagnostic testing. And there are right now a number of new tests being planned and in the development pipeline specifically for this footprint of instruments. Tests for sort of neglected diseases that otherwise have not been supported or supplied very well by some of the automated PCR platform companies. Another innovation that which COVID-19 sort of prompted was a real examination of testing throughput, and this chart here, provides the throughput, the daily throughputs of some of the main PCR platforms currently in use. The main takeaway is that, obviously through the pressure of testing, there were extra shifts put in onto labs, and just a small, modest increase, an extra 4 to 6 hours could increase the throughput of these laboratories by an extra 50%. And that's something which obviously in the past had not been a requirement, but became a real opportunity to explore in many settings during the course of the pandemic. Now I want to switch a little bit to talking about, I would say probably in the testing world, one of the most significant innovations, and that's the introduction of rapid antigen tests. And it took about 6 months after the first PCR tests were available and were sort of starting to get widely implemented. It took about 6 months for rapid antigen tests, high quality rapid antigen tests, to become available. And so from in late September 2020, the first 2 of these received the WHO emergency use listing. And at the time, the world at that time was well into scaling up and operating COVID-19 testing using PCR. And the innovation that needed to occur around these rapid antigen tests was largely driven by the introduction of a sort of a more specific antibody sort of component for these antigen tests. So in other words, an antibody that was specific for SARS-CoV-2, because some of the early antigen tests were based on antibodies that had been developed for the SARS-CoV-1 as sort of a virus, and so while they could pick up SARS-CoV-2, there were some specificity issues, and frankly, there were also some significant sensitivity issues. But the development of these improved antibodies allowed these better performing antigen tests to become available. The value proposition of these tests was and is pretty strong compared to, at the time, a cost per test of sort of $10 to $20 for PCR. These antigen tests costed just $5 and could be run within sort of 10 to 20 minutes, as opposed to 2 to 5 days with most of the PCRs that were being run at the time. And this allowed countries to decentralize testing, have sort of less skilled staff running the tests, allowed them countries to significantly increase the number of tests being run, and to run tests in a wider range of what we call sort of use cases, so the wider range of settings, both for symptomatic patients and for asymptomatic patients. And so the overall value proposition was high. Now, back in September last year, as these tests became available, another sort of innovative effort was undertaken in a very rapid way. So just as the antigen tests were developed very rapidly, and within a matter of a few months, and basically got the FDA and WEU approvals within 6 months or less. There was I would say roughly within 1 month, there was an effort taken, actually within maybe 3 weeks, there was an effort taken to provide $100 million of backing from the Gates Foundation to support the secure supply of these antigen tests. Because there was a concern that, just like with the PCR tests, the high-performing PCR tests, there was a concern that low and middle-income countries would not get adequate access to these tests because of the sort of the severe, the very high demand within the market, and the competition for these tests with higher incomes sort of countries. And this slide sort of illustrates that there were 120 million tests made available and in anticipation of very high demand. And these are, the slide also sort of illustrates the sort of term sheets for these, or the sort of, you know, the specifications for that supply commitment made available. Now, that was for a 6-month period, so it's now ended. And I would say, even though, so there was lower demand at the end of the day, and I'll go into the reasons for that in a minute, but that helped to secure supply of these tests and to mobilize countries and partners and donors to make rapid antigen tests available and to help get them scaled up and help get them funded. So that was a very important, I would say, I would call it an innovation, because that type of financial arrangement might otherwise take months to set in place, and you know, a lot more time and effort put into doing extensive, you know, feasibility assessments and negotiations and so on. So this is all achieved within a matter of weeks. Now, just a quick note about rapid antigen tests, and this is probably information that you all know already, but there has been a lot of debate about whether these, you know, with all the values and the benefits that I described earlier, a lot of debate as to whether rapid antigen tests are good enough for COVID-19 diagnostics. And I think for some people that the answer is clear, and they say, well, yes, they are. And for others, there's still concern. And part of the concern is not so much around specificity, I think, anymore, because the specificity of these tests is uniformly pretty high, so well above 99%. And that's good, because, you know, it demonstrates that these tests can be used, particularly in low prevalence settings. So you know, it sort of enables the sort of positive predictive value to be you know, high, very high, and to have a lot of confidence that even in low prevalence settings, that, you know, positives that you get are true positives. The sensitivity is, as one would expect with antigen-based testing, it's a simple manual, visually read lateral flow assays, as has been observed with flu tests and so on, is lower. And so, but it's sort of believed to sit somewhere between 75 and 85% on average, but within patients who are symptomatic to be potentially, you know, well over 80 and maybe even over 90% sensitive within patients that are symptomatic within the first few days of their infection. And so there are a lot of data on performance in symptomatic patients, and less data on performance in asymptomatic patients, and more data being gathered. It is important to understand performance in asymptomatic patients. By asymptomatic, I mean patients who are in the sort of the pre-symptom phase, who have not yet established symptoms but may still be infectious, as well as patients that are sort of post the symptomatic phase and are actually just recovering. You know, patients who are in the pre-symptomatic phase are also obviously patients that would need to, individuals that would need to be diagnosed. Infection would need to be diagnosed in those individuals for settings like, you know, workplaces or borders or schools and so on. And so over the coming weeks and months, we expect to see a lot more data coming out about the performance of antigen tests in that sort of pre-symptomatic phase. But overall, a sort of generally positive picture about antigen tests with some caveats. Now, this is a sort of, I guess, a heat map from a recent study, which some of you may have seen, but it provides, I think, an interesting perspective, which I think is often overlooked when one when we're in the debate around antigen tests versus PCR. PCR obviously has much higher sensitivity, but the turnaround time for PCR tests, for any of you who may have gotten yourself tested, is not fast. I think there are some settings of probably a very small percentage of all PCRs done where you can get the result the same day, or maybe the next day, or maybe within 2 days. But certainly at the sort of peak of the epidemic, when testing demand is very high, it can sometimes take days or over a week to get a PCR result back, and that's not specific to LMICs. It's also a feature of testing in some high-income countries as well. Now, this study sort of modeled this out and looked at the thresholds at which antigen tests actually have a better impact on epidemic control. And the key takeaway is that the PCR test turnaround time needs to be sort of at the, should I say, at the performance of current antigen tests, so somewhere between sort of 80 to 90%. The test turnaround time of PCR, the performance antigen test being 80 to 90% sensitive. The test turnaround time for PCR needs to be somewhere in the region of sort of, maybe at 1 to maybe 1.5 days, in order to have to be superior to antigen tests in epidemic control. And by epidemic control, I mean being able to identify individuals who are infected early and take the appropriate follow-on actions to isolate and prevent further transmission. And that's something which I think is often overlooked in the debate around antigen tests and PCR, and I think deserves more attention. From the perspective of how we actually, despite all the testing that we're doing, are we actually controlling the pandemic, and are we bringing it under control? And effective epidemic control based on testing is dependent on the full cascade, the test, and for those who are positive, to isolate and prevent sort of further transmission. And potentially go as, if possible, go as far as identifying contacts and isolating them as well. But certainly isolating those who are diagnosed as positive. And so that's where I think right now in terms of moving forward, antigen tests represent a sort of a positive opportunity to be more effective in epidemic control. So I want to just dwell a little bit around test turnaround time, and this is relevant because it's a space in which where COVID-19 has resulted in quite a bit of innovation and change, but it also provides an opportunity for other diseases to benefit. Now, these are all the charts on this slide relates to data collected in sort of 2018 and 2019 before COVID, and they're for HIV testing, sort of point of care, viral load, and point of care early infant diagnosis in a number of low and middle income countries in Africa. And the chart on the top left shows sort of the average by a number of countries, the average test turnaround time from some published data for nucleic acid tests. And you can see that the test turnaround time can range from 1 month to almost 4 months. And that's because of just operational and logistic challenges in getting samples shipped, run to the lab, getting results back, and then delivered back to patients. And there's also a certain percentage of test results that just never get back to patients because of loss to follow-up. Patients don't come back because of these lengthy delays. And that ranges from 40%, up to about 80 or 90%. So there's a significant loss to follow-up that occurs. Now, when the graph on the right, when one looks into this to try and figure out what's the cause, and the pie chart on the sort of bottom left, getting results returned from the clinic, and then results returned from the lab to the clinic, and from the clinic to the patient, contribute the most to the delays in test turnaround time. The actual testing process within the laboratory is actually a fairly short process. Seems to happen pretty quickly, and even the sample transportation step, it seems to be a relatively short step. Samples may be picked up from a remote clinic and may be transported to the lab once a week. So then it's fairly consistent. What introduces the most delays is the data systems to get results back to patients and to get back to clinics, and then to get results back to patients. And so there are opportunities there for system improvement. Now, what COVID-19 has done is that it's really collapsed a lot of these delays, and even though test turnaround times are maybe a frustrating sort of maybe 4 or 5 days or a week, that is dramatically different to sort of 2 to 3 months as it was before. I think moving forward, that's going to be a real opportunity for other diseases to see if these same laboratories, which also conduct TB and HIV testing and TB and hepatitis, if they can achieve similar test turnaround times as they have with COVID. A second area of system innovation, just related to what I described just now, is diagnostic data visibility. Now, for the HIV pandemic, UNAIDS keeps a dashboard of a number of key metrics for the HIV response, and that sort of captures how well we're doing in managing the HIV globally, and they track a number of key metrics by country, and even within at a subnational level within countries. But often many countries and many governments don't have those data as clearly and clearly articulated and available in real time. COVID, however, as you know, as we all know, has changed that completely, and data are often reported every day, the number of tests run, and there are a number of websites that have these data available that one can look at and look at testing rates and look at positivity rates and so on. Find is a good example of this, and they have a nice tracker for this, and that's because every single test result is reported and is tracked and reported not only to sort of national authorities, but then reported up into international sort of tracking systems. And this is dependent on a data system that has been established very rapidly. Initially, in the phase 1 of the pandemic, in terms of testing, from PCR laboratories to sort of national COVID task force, but then subsequently and in a process that's currently ongoing right now, from rapid tests that are being conducted and more remote sites, that information is being communicated electronically to district health offices, and then to the central sort of COVID data system, sort of managed by the COVID task force, and then put onto dashboards and then communicated internationally. The rapid test or the RDT data visualization is still a work in progress, and our observation is that there are a number of different technology apps and apps that are most often being put onto small tablets or onto cell phones, mobile phones, and these apps, for the most part, are sort of allowing the test operator to enter the test results and some details around the patient, and to have that sort of sent electronically in real time right after the test is run. There are some apps that are coming out that incorporate an actual reading of the test result. But I think, as many of you know, those apps are promising. They do face some regulatory challenges because of the potential for these apps to be considered sort of software as a medical device, and so because they're involved in delivering the test result. But there are definitely are innovations on that front that are occurring right now, and as many of you know, some of these apps have been developed for malaria and are very important in malaria surveillance. So we expect that if you think about the landscape for rapid tests, simple lateral flow assays, that's dominated by malaria testing, dominated by HIV testing, probably maybe close to 1 billion of those and other tests run every year. And most of those tests simply not really visible electronically. The results captured on paper and communicated otherwise. What I think we're going to see, and what we're already starting to see, is the rapid antigen tests significant proportions of those tests are starting to be captured using these apps, and which is a dramatic change within 1 year, and that could cascade into similar usages for HIV and malaria tests down the line. Another innovative aspect of COVID-19 testing has been around training, and training is a very sort of traditional thing. It's done. It's considered obviously a very important core aspect of introducing a new technology, and there's a traditional way of doing it, and it usually involves convening workshops and people spending days in a room, sort of learning the theory and then doing some practical work and then doing an exam and getting certified. Now, in the course of the COVID-19 sort of epidemic, training programs around rapid antigen tests were developed. They were developed very quickly. Previous training programs, so it could have taken months or years to pull together the associated materials. For COVID-19, they were developed within a couple of months. Obviously leveraging previous experience of rapid test training, and made available, and then scaled up dramatically. And so I want to just highlight and illustrate the example of work that ASLM has conducted, and through their initiative, together with partners such as FIND and Africa CDC, WHO, AMREF, HI, and others. They have established this training package, and over the last 6 months, trained over 3,000 sites within 14 countries in Africa, and almost 10,000 test operators, which is a really significant pace. And they've used quite a lot of innovative approaches to get this done, including making the testing available online, and amenable to training without necessarily that sort of formal meeting in a room and going to a workshop, and that this is being evolved even further to have providing testing that can be viewed on a mobile phone or a tablet, and conducted basically without necessarily needing a sort of training, a live training sort of operator. Present for every training, but of course there would need to be supervision of the training process and certification of those who've been trained. Now, I want to sort of bring a lot of this together by talking about what we see as the sort of future of COVID-19 testing, and just dwell a little bit on some of the innovations that I've described, but also think about what future innovations are needed. This is the sort of the sort of pathway of the future of COVID-19 testing as we see it. We know that while 2020 was the year of testing for COVID, testing was the primary intervention. Testing and isolation were the primary interventions to control the pandemic. Moving forward, of course, vaccines have become much more of a dominant topic, but we anticipate that both vaccines and tests have to be implemented as two complementary interventions and means for control. And COVID-19 testing is going to have to continue to grow and expand, and to be done at even higher rates, and to be used for a number of functions, including ongoing surveillance to detect and respond quickly to vaccine outbreaks, but also areas where vaccine coverage has not been adequate. So there's an aspect of vaccines and antigen tests working well together that I think is still to be sort of fully appreciated and fully built into the disease control programs of many countries, and that's what we consider sort of part of the normalization of COVID-19 testing. And so, building COVID-19 testing into the routine assays or routine tests that occur at primary healthcare level and in other settings on an ongoing basis. Just as in many countries, there'll be rapid there'll be tests for other diseases, whether it's diabetes or or other infectious diseases, HIV and or syphilis or anything else. This is going to be COVID-19 is probably going to be one of those routine tests. And for that to happen, the sort of the further trajectory of innovation is probably going to have to include tests that are sort of cheaper than what I've described so far. So cheaper than the sort of $5 or $2.50 tests, but probably the sort of $1 tests or even below. Self tests are probably going to have to become much more prevalent. And there's also going to have to be a system, a sort of better system service delivery approach where the sort of the linkage to care or linkage after testing to the appropriate service happens. So the appropriate action, whether it's linkage into sort of high quality care, including oxygen and potential sort of new therapeutics coming down the line for those patients who are symptomatic and on a poor clinical trajectory, as well as isolation and the control of transmission for patients who test positive. And without that linkage, then the testing is unlikely to be of much value from an epidemic control perspective. And so this is some of the future of testing as we see it. Now, lastly, from the perspective of benefits for other diseases, we see that COVID-19 has sort of just, I think in many ways, revolutionized testing. It had impact on the testing infrastructure. It's had impact on the testing supply chain. It's impacted the development of new technologies. It's impacted data systems and made testing much more visible. And it's also sort of laid bare some of the weaknesses that exist within diagnostic capacity at primary healthcare level. And that's going to be, I think, a priority moving forward in terms of pandemic preparedness and global health security, a need to strengthen diagnostics at that level. And that will benefit our other diseases as well. The overall diagnostics market is going to need to grow to accommodate this and to support this, not only for COVID-19, but for other diseases. I think there's now, in some ways, an impatience that given the significant deaths that occur with other diseases, whether it's from diabetes or heart disease or HIV or TB or hepatitis, these are pandemics in their own right, and there's an interest in addressing those, and diagnostics would be the forefront of that, and that the innovation that occurs around COVID-19, and we're still starting to see beyond the rapid antigen tests, we're starting to see some point of care nucleic acid platforms become available. These are going to be important and valuable for other diseases, where the use cases and the sort of normative guidance is actually much stronger for point of care testing already. And this will all, I think, as these new technologies become available, they will start to get implemented within a testing infrastructure that has been well primed with by COVID-19, basically made more efficient. Instruments that have been brought out of the research labs and made visible and put to work, as well as extra shifts that have been put on to use the testing infrastructure. It should be possible to test not only for COVID-19 moving forward, but to ensure that adequate testing for HIV, for TB, and hepatitis and other diseases occurs as well. So I'll end there, and I'll open up for any questions. Thank you.
Thank you, Trevor. This is fantastic overview of COVID-19 diagnostics. The floor is open for questions. Please identify yourself and ask questions. Okay, I'm going to ask a question to just get everybody started. Trevor, what is your vision of rollout of these rapid antigen testing solutions along with together with the vaccine rollout? How do you think that can be accomplished, and what should the governments, how should they plan for it? Because the governments that are fighting the pandemic response, they certainly have 70% to 30% ratio of rapid antigen testing to PCR, but other governments, other settings, how do you think they should plan for it?
So I think what's going to be most important as vaccines roll out is for sort of rapid identification of either breakthroughs or due to variants, sort of like, and as I mentioned, sort of areas where maybe vaccine coverage hasn't been adequate, and being able to quickly identify that. The purpose of vaccination campaigns and the whole publicity that goes around that is really about getting control. So not only and reducing risk, not only for individuals, but for the population at large. And being blind about outbreaks and being blind about breakthroughs and gaps is not going to be acceptable. And so there needs to be adequate investment in a complementary testing infrastructure that's running at the same time, screening people who are falling ill, continuing to screen people who are sort of in the early stages of vaccination, still not vaccinated, and making sure that they if they are infected, they aren't transmitting infection. And that can only probably be achieved through probably through a combination of PCR and antigen tests. But I would say antigen tests will probably play a bigger role because they're going to have to be a lot cheaper. They're going to have to be well under $1, and they to be affordable by many countries. Some of the higher income countries can probably afford a higher price test, but they're going to have to be cheap and easy to use, widely deployable. Self tests could play a big role if they can be run, if they can prevent the risk of test operators obviously at risk of infection, even if they're vaccinated. And so if many people can self-test before they maybe go to work or before they go to schools or even at the border, it makes it easy. It just makes it much more operationally feasible to test a lot of people at one time. So I would say cheaper tests, easy to use tests, widely deployed. And from a budget perspective, vaccines are going to consume a lot of the COVID-19 sort of budgets for many countries. The testing is is going to have to be at a significant scale. It is hopefully going to be cheaper, significantly cheaper than vaccines eventually. And it's also, I think, really about putting aside a certain quantity of tests and of budget and making that available for testing. PCR will continue to be used. It's because it is so much of a gold standard. And we haven't seen a diminution of PCR demand despite the introduction of antigen tests. PCR tests continue to be used at a very high rate, and we expect that to continue. The PCR tests have their own application, and they have their own value.
Thank you, Trevor. We have a question from Professor Yorkos. She asks you, what is your view of antibody testing or saliva-based testing and of wastewater testing? I think you probably addressed antibody, saliva-based and wastewater testing. She's probably talking about saliva direct.
Yes, I would say that. So firstly, antibody testing, just that alone, I think right now, I mean, what has looked at those tests, and even WHO came out with some guidance that was quite a while ago, last year, that was pretty clear, pretty direct about the utility from a diagnostic perspective, which is certainly for acute infection very low. Maybe one of the potential use cases for antibody tests is for people who've for surveillance, obviously important if you're looking to capture a snapshot within a certain space of time. That can be useful. Of course, antibodies do wane, and that can complicate things. There may be a lot of private use for antibody tests, so people who maybe have been vaccinated and worried about whether maybe they didn't experience symptoms, worried if they've become immune, or if the vaccine worked. That could be a use. That could be a use that the antibody tests are useful. I expect there'll be a lot of use of antibody tests in general. Just probably not a lot of value beyond surveillance for public health.
And wastewater testing?
So wastewater testing and then saliva testing. Wastewater testing, to be honest, I haven't given much thought to. I don't think it is of much value. I'm trying to think what you would take. Perhaps there is a value if you had a positive wastewater result what would you do with that? So I don't know if there's a lot of value in that. And saliva-based tests, I think, I think there's a lot of interest in this. I think, then the performance in the studies suggests that, in some cases it's actually a very good sample. In others cases, maybe not so good. I think the purists in sample sort of sample collection don't like saliva that much because it's it's a very heterogeneous sample, and the quality is not always good. People can swap saliva, and so knowing that the provenance of the virus is it may not always be very clear. So not it's a very popular from an ease of collection perspective. Maybe not so popular amongst the purists of sample collection.
So there's another question from Joanna Trees. She says that antibody testing for MIS-C still remains important. Clinical use is important. Yeah, and for surveillance, of course, it's important. Yeah. Susan Bartlett is asking you, do you have suggestions or dealing with individuals who are hesitant to be tested?
From a concern about having a nasopharyngeal specimen taken, well, nasal samples are easy to collect, but I think if a person doesn't want to be tested, all the test does is sort of confirm infection. I mean, in the absence of an actual virological test result, one can still manage the disease based on symptoms. It's just maybe slightly more risky, but many people go through their COVID infections that way. The vast majority of people have gone through COVID infection that way. Getting a test early may help with just getting quickly and sort of more rapidly into the right sort of channel of care. Of course, monitoring your oxygen sats and your clinical condition is so these are some of the primary indicators for whether you get hospitalized and what type of care you get clinically. So it's probably not a train smash, but it's a value. For the antigen tests probably have the greatest value for epidemic control and preventing transmission, I think.
Thank you. As far as these countries, the ASLM trained 14 countries, were they all in Africa or were they elsewhere as well? Yeah,
they're all in Africa. And I illustrated sort of I think over 3,000 facilities trained across 14 countries. The training is actually far beyond that. We didn't have the exact number of facilities trained in the other countries. It was a very rapid scale up. They could be potentially tens of countries using the training curriculum right now. WHO also has a training curriculum that's been implemented in a number of different regions, and that's gone very well. I don't have a map of training efforts in, say, other regions in Asia or South Central or North America, but I know there are efforts to public efforts to roll that out, and governments are implementing their training programs, and I think those have been going sort of fairly well from what I understand.
Thank you. There's another question from Dr. Yorkos. As vaccination coverage increases, do you see a time when testing will not need to be done? This would be extremely, it'll be a cost-saving initiative then.
Yeah, I mean, there's obviously, vaccination coverage that could sort of lead to a real control of COVID-19, where the risk of infection is so low that you that if you have certain symptoms, there's a higher probability of something else, not COVID. In which case, for individuals, the decision to test for COVID, that may reduce in importance because maybe it's a much higher risk you have, flu or something else. And even on a population level, it could be that screening of asymptomatic people at airports. And I think we see right now that traveling with the vaccination card may be adequate. Some of the new EU rules suggest that you could travel with the vaccination card although individual member states can decide whether or not to add a PCR test for that. So some of the asymptomatic screening may go down a lot. But COVID testing, I think it's going to be, COVID's going to be here for a long time, maybe forever. And it'll be a test that clinicians or people who sort of in charge of managing population-based disease will always have and always need to have available, so that they can sort of question and interrogate a patient or a person that they concerned about. So there'll always be some people at a more elevated risk for which a test will be needed. I think just the rate of testing is probably will go down. It won't be this hundreds of millions or billions of tests being run in a year. It'll be much lower, but it'll continue to be one of the tools needed.
So Dr. Joanna Trees asks you, is testing not even more important? Do you not want to cover the breakthrough infection and keep track on variants? Would you like to comment on variants and antigen tests, because it's a common question? And
variants and antigen tests, maybe just talk about that quickly. And actually there was a paper published, I think just the last day or so, that found a mutation in the nucleocapsid sort of gene, which it was suggested that perhaps that was associated with some negative antigen tests that were found in Italy. I don't know if that's going to be very common or not, but it doesn't seem that the spike protein mutations that are occurring with most of the variants so far it's a different protein. It doesn't really seem to affect. It's obviously a different protein to what the antigen tests are sort of focused on. So antigen tests so far seem to be not affected, but that's not to say that with the the rate of mutations that occurs, that they may not in the future be mutations in the nucleocapsid protein. It doesn't seem to be the case right now, and I suspect it'll always be slow if it does occur. The first part of the question was about
saying that testing will be more important. It is an important component of a pandemic.
Yeah, I think it's a very
control.
important. Sorry to come in earlier. I think it's a very important part of control, even in the context of vaccines, because of the need to monitor for breakthroughs. And so even if you're vaccinated, 90% of the population, you need to have an ongoing monitoring. So people coming in falling sick, for a while, there's going to be differential. One of the differential diagnoses of the tests you'd run is a COVID test. People coming in with symptoms that look like COVID, because you're going to want to have that surveillance going on for a while, and that's going to allow you to pick up, like I said, areas where maybe vaccination coverage wasn't as good as we thought, pockets where people just didn't not undocumented people as much, but just maybe where coverage is a lot higher, a lot lower than maybe it was thought, and breakthroughs in particular. So mutations, and I think antigen tests, provided the nucleocapsid sort of mutation rate remains low, and doesn't affect the antigen test, there will be a good tool for that sort of screening on an ongoing basis. So very rapid tests can be done in very decentralized sort of settings, potentially even self-tests that will hopefully pick up sort of virus that's starting to circulate, and small sort of outbreaks that start to sort of circulate with the vaccinations, as vaccination coverage sort of expands. Already we're looking at a third dose for vaccinations. We don't know yet what the frequency of testing of vaccination needs to be, and what the waning of immunity might be post-vaccination. So these are a lot to be learned over the coming year or so.
Trevor, one last question before I let you go. Do you recommend, like in HIV, like in India, the current pandemic situation, they are concerned about, the low sensitivity, but, in a pandemic setting, that sensitivity can be easily questioned because the prevalence is high. But to those skeptics, do you recommend use of the serial testing strategy or parallel testing strategy that we used in HIV, and it worked so well in African countries? But why is there so much hesitancy in using antigen tests sometimes in pandemic settings, or even in Canada. It's got nothing to do with accuracy. I feel it's got everything to do with the lab control.
Yeah, I think there was a lot of people were not familiar with predictive values, and they had to become very, very familiar with what predictive values mean. And when you establish a gold standard like PCR, it's very, because the sensitivity is so high, anytime you step away from that, you ask a clinician, an individual, what do you think about a test that captures maybe 4 out of 5 people versus sort of almost 5 out of 5. And from an individual perspective, most people say, well, I don't really like that. If I can avoid it, I'd rather go for a more sensitive test. And so many people don't think on a population basis. They don't place value in a test except for the epidemiologist. Value tests from a population disease control perspective. And that's been, I think, very difficult to get across because of the way that we as individuals look at tests. But I think it's like I said, like we've become very familiar with predictive values. We increasingly, I think, will become familiar with the value of a test that has less, maybe lower sensitivity, and so there's a higher risk of maybe missing infections for individuals, but on a population basis, because of the speed and the scale at which they can be done, has a much higher capability of catching infections and getting the follow-on action to happen than PCR. And that's I think it's just going to take time for that concept or those concepts to sort of become much more accepted. Maybe antigen tests will become much higher performing, and they may also be sort of rapid nucleic acid tests that are also cheap. Maybe not as cheap as less than $1, but certainly cheap enough to be deployed widely, which might get around some of this.
Great.
I could go on quite a bit on this.
I know. It's so wonderful to hear from you. I think we have no more questions. We should let you go. It's 20 minutes of question time. Thank you so much, Trevor, on behalf of all our team, on behalf of Susan. And they said, thank you for a fascinating talk. Everybody loved it. Thank you so much for coming and for educating us on this.
You're welcome. Very happy to. Hope it was useful.